Hi, everyone. I hope you can hear me. This is Barb Cochran. You're not going to see me. You're just going to hear me. I am the Associate Director for the Northwest Geriatrics Workforce Enhancement Center, which is sponsoring this Geriatric Healthcare Lecture Series. I'm also on faculty here in the School of Nursing, which is co-sponsoring the series. And before we get into our talk, I'd just like to remind you that if you're hearing from some people in Alaska, Alaska is not participating in this series, and but if you are interested in connecting from one of the other sites, your site coordinator should be able to provide you with information from the other states. And that information that you should have is includes a profile form if you haven't filled it out yet, an evaluation form for this specific lecture. You should have information about how to link to our continuing education system so that you can get CE credits for this lecture. And the lectures are posted on our Northwest Geriatric Workforce Enhancement website soon after they are delivered live. I just need to convert them into a YouTube video and get it posted. So you can access the previous lectures as well as about 90 other lectures from previous years at nwgwec.org, and just go to the link that says our activities and archive lectures, and you should be able to see those there. We have a great lecturer today. She is Margaret Heitkemper. She's a professor and chair from our Department of Biobehavioral Nursing and Health Informatics. She's also adjunct professor in the Division of Gastroenterology, and she directs the Center of Research on Management of Sleep Disturbances at the University of Washington. She received her BSN from Seattle University, her master's from the University of Washington, and a PhD in physiology and biophysics from the University of Illinois in Chicago. She leads an interdisciplinary team focused on the study of the pathophysiology and non-pharmacological management of individuals with irritable bowel syndrome, or IBS. And at this time, her team is studying the interaction of stress, sleep, genetics, and symptoms such as pain in women with IBS. She is a true international expert on gastrointestinal health. So please welcome Margaret Heitkemper.
Well, thank you. Blew it right off the bat. I forgot to turn on the voice. So hi, I was just saying I'm just very excited to be here. This is a class I look forward to doing. Actually, it was probably about 20 years ago. I used to co-teach this class. So it's great to see that the course is thriving and that people are still interested in aging. But I'll tell you what the bottom line for the gut in terms of aging is that it holds up pretty well. So most of what we see in the GI tract related to aging is our increased risk for diseases and disorders. So I'll talk a little bit about those and also talk about what we do know about some age-related changes that occur. And we'll take the approach of going from the top to the bottom. Okay, so Barb. Okay, I'll do it down there. So we'll start with the mouth. Probably the thing that is most notable as we get older is that we have a decreased ability to produce saliva. And saliva is extremely important because it helps to mix up the food, and that allows for greater exposure of the taste receptors, which are all over the tongue. And with that saliva, to actually sort of coat the food in a way that makes it easier to pass down through the esophagus. So that decreased production of saliva is responsible for some of the changes that we see. We know that that saliva now also has microbiome, and that there is research going on looking at what are age-related changes in that microbiome that occurs, and how might that contribute to potential disorders such as increasing cavities as we get older. Probably the biggest thing, though, that contributes to changes in saliva are medications that older adults are likely to be on. So drugs that have anticholinergic properties, drugs that are used for management of Parkinson's, all of these can contribute or enhance changes in saliva that occur. Those changes in taste or in saliva can affect taste perception. So as we get older, we lose taste buds. We know that. And of course, if you have a history of smoking, you're more likely to experience changes in taste perception. But we don't really know what's the magical number of taste buds you need to have. But we do know that we have a need. There's a tendency to want to eat more sweets as we get older. And part of that has to do with changes in taste perception. So here are some characteristics that we see in older adults. So the most common complaint is the dry mouth, and certainly people who have autoimmune diseases and again, medications. It's most commonly related to tricyclic antidepressants and anti-Parkinson's medication. The side effects in terms of variety of agents that affect taste perception, that it changes as we get older. The other problem that we see, again, mostly due to pathology, are problems in moving the bolus from the mouth to the back of the throat and down to the esophagus. So people who've experienced stroke, who have MS, people who have dementia may have problems in swallowing. We know that about half of nursing home residents have difficulty swallowing, just moving the bolus to the back of the mouth. And what we can see some symptoms of this for people who can't express that they're having problems with swallowing, symptoms such as coughing when they're swallowing, or nasal regurgitation of foods, meaning that the food is in the back of the throat and it's actually migrating up and coming out through the nose. Now, swallowing and complaints of swallowing is a very important symptom. So when someone says they have difficulty swallowing, that needs to be evaluated because it could be a sign of cancer. One of the things we know, as I mentioned earlier, is the gut diseases, in particular cancers of the GI tract. If you think about the gut, it's a long tube, kind of tortuous in places, and it has muscle layers that help move things through it. And it also has nerve layers that help coordinate that muscle activity. So when you have a bolus in the back of the throat, you have relaxation of the esophagus, but then contraction as the bolus moves down. And so when we get neuromuscular conditions or we lose those neurons, what we have is either incoordination or difficulty getting the bolus down. But those are most commonly related to neurological conditions. So my point about swallowing being an important symptom is that it may be a sign of a mass or cancer or dysplasia, and it should always be evaluated because swallowing difficulties are not a normal age-related change, not an age-related change. So the difficulties could be to what's going on in the central nervous system because it's a very coordinated, much influence, it's a voluntary activity. So we know the brain is involved. So changes in the brain, dementia, hypoxic changes, etc., can have an influence. Also, if we don't have as much saliva, it makes it difficult for the bolus to move down. Another factor that's very important in older adults because of medication use is damage due to medication. There are certain categories of medications that can be irritating to the mucosa of the throat as well as the esophagus. So that's another factor that we look at clinically when somebody is having problems with swallowing. Of the symptoms, in addition to dry mouth, another commonly reported symptom of adults in this country, not necessarily older adults, but starting about middle age, is heartburn. It is the most common problem and is extremely costly. Look at all the over-the-counter drugs that are available to treat heartburn. It is an economic issue. And it's actually associated with reduced quality of life. People who complain of heartburn also say that their quality of life is affected by it. Now, we all experience an occasional episode of heartburn. Often it's diet related, but again, it has to do with repeated episodes of heartburn. Is something that needs to be evaluated and potentially managed. So what happens as we get older is we really don't see pathology in the esophagus unless there's disease. So the motility, there's literature that says the motility or the contraction in the esophagus decreases as we get older. But if you're a healthy older person, you shouldn't see changes in your esophagus. Unfortunately, many of the early studies that showed that there were changes were most frequently done in a relatively captive population, either in the nursing home or in a VA site. But we do know that as we get older, for some of us, we may experience a laxening of our lower esophageal sphincter. So as food comes down the esophagus and then enters into the stomach, there's a sphincter that naturally controls the delivery of that bolus into the stomach. And it's called the lower esophageal sphincter. And it sits right there at the diaphragm. And that's a very important sphincter because under physiologic conditions, the pressure in the thoracic cavity is less than the pressure in the stomach. So if we didn't have that sphincter and we lay down at night, things would naturally go from the stomach into the esophagus. So having that lower esophageal sphincter, high pressure zone, is a very important barrier. For some individuals, as they get older, that sphincter reduces its pressure and allows then for gastric contents that include hydrochloric acid, so it's acidic. It has an enzyme called pepsin, which helps to break down proteins. It can also have bile if there's been reflux from the small intestine into the stomach. So you can see where having reduced pressure in your lower esophageal sphincter would allow exposure of that lower part of the esophagus to some corrosive elements. So what are some risk factors? Well, obesity is one. And it kind of makes sense because if you have increased body fat, you have even greater pressure on the stomach and sort of facilitates that reflux. Anything that widens the space for the part of the stomach to float upwards into the thoracic cavity. And that's a condition called hiatal hernia. We know that as we get older, the risk for developing hiatal hernia increases. So that's a situation where the upper part of the stomach either permanently migrates into the thoracic cavity or it slides back and forth. And once it's diagnosed, there are either surgical procedures to sort of bring it back down under the diaphragm, or it's treated medically with drugs that affect the corrosive nature of what's in the stomach. So while there's still reflux, it's not as corrosive. So heartburn, very, very common. We all have it. My favorite scenario is you go out to dinner, you have a high-fat meal, probably something that has sour cream or butter or it's red meat, high fat, and perhaps the individual drinks a little alcohol with that as well. And then after you have that heavy meal, on your way out, you grab the peppermint at the cashier stand. What does peppermint do? It relaxes the lower esophageal sphincter. It's actually a smooth muscle relaxant. And then the person lays down, goes to bed, and probably either in the morning or during the night wakes up with this burning sensation of reflux. So that happens sort of like everyday life for some people. And so, but this is reflux that can occur over and over, perhaps with lifting things, perhaps with being stressed, perhaps with what you ate or whatever. And the worry is that over time, that can change the cells in the lower part of the esophagus. So now, instead of being nice columnar cells all lined up smooth, is that those cell changes, metaplasia, possibly dysplasia occurring, sort of like with almost like scar tissue almost. And that's a condition known as Barrett's esophagus. It's a very small percentage of people with chronic heartburn who go on to develop Barrett's esophagus. But for that small percent, there are needs to have surveillance done, such as monitoring to ensure that the dysplasia does not result in cancer. Again, a small percentage of people, lots of debate about how much surveillance should be done. Because if you think about it, if everybody who experienced some heartburn had an upper endoscopy, that would be very, very costly. So there's a lot of clinical judgments that gastroenterologists spend thinking about who's at risk, who's not at risk, etc. So functional dyspepsia, that's where you have these symptoms and you have this functional complaint. If we look at it relative to age, what we see is that as we get older, it increases, and it tends to increase more in women. Why that is, we're not sure. And in contrast, in this particular PowerPoint, the contrast group, it's the condition that I study, which is irritable bowel syndrome. And it tends to decrease as women get older. So irritable bowel syndrome, and I'm always sad that I don't have a lot of time to talk about it, is for an individual who has chronic abdominal pain associated with either diarrhea or constipation. And one of the reasons I don't talk about it in this class too much is because it tends to decrease as we get older. I remember when I used to teach this course, one of the guest lecturers would make a point about the PowerPoints. It was always that you know, certain things went up, but most of our functional capacity tended to go down. And the one part of our body that tends to increase is our earlobes. So something does get longer or better, but a lot of things go down. IBS is one of those things that tends to go down. And more than likely, it's because of changes that occur with pain as we get older. But anyway, I would also say it's likely that we haven't done enough research on it, and we know more about it in younger people. Okay, so all of this is sort of a setup for a problem that we should care a lot about that's associated with aging, which is esophageal cancer. And I was trying to make the point earlier, which is that the gut, for all of its nerves and muscles to coordinate motility and secretion, because the gut secretes a lot of secretion, has a lot of secretion that we need for digestion and absorption, is that it doesn't have a whole lot of pain fibers. So part of the reasons that cancers tend to be so deadly in the gut is because we don't have a lot of pain fiber. So cell changes occur, and they occur without symptoms, which is why something like swallowing difficulties, if it's a new onset, etc., should be evaluated. So esophageal cancer is associated with aging. And they're really fascinating demographic numbers when it comes to esophageal cancer and how it's changing, which tells us that there's clearly an environmental component. Smoking is associated with esophageal cancer. So the early signs are subtle. It's diagnosed by a biopsy. And this is just showing some graphic endoscopic pictures of what the endoscopist would see with the scope. So that's the esophagus, okay? Let's move anatomically down to the stomach. So what happens as we get older? Our ability to contract and secrete acid and pepsin does not change drastically as we get older. If we are more likely to succumb to another problem than to have it be related to changes in the gut. But as we get older, we are at risk for upper GI bleeding if we have another health problem, which is arthritis, a very common problem. So the way that those are treated is with NSAIDs, non-steroidal anti-inflammatory agents. And these drugs are associated with an increased risk of upper GI bleeding. What that means is that nice, rich, very well blood supplied stomach lining actually experiences an erosion in the mucosa that can go down as deep as the muscle and nerve layers, and you get bleeding that occurs. Another problem that we see at a higher prevalence in older individual is chronic atrophic gastritis. So that scenario that I said about alcohol and food, etc., that's another scenario that can lead to chronic inflammation of the lining of the stomach as well. When I was taking Psych 101 some years ago, we learned that ulcers occur because of stress. That some people handle stress by cardiovascular reactivity and they have high blood pressure. And then there's this whole other people who it all gets played out in the stomach. We know now that that's not true, essentially. Ulcers really have two causes, two root causes. One is NSAIDs, which again, in this country, in older populations with access to NSAIDs, is an important causative factor. The other is a bacteria, H. pylori. And this has only been in the last 25 years or so that we've realized that bacteria that harbor in the gut can contribute to ulcers. They can destroy the tissue in much of the same way that certain drugs can destroy the tissue. H. pylori as a cause of bleeding and ulcers is much more common in other parts of the world than in the US. And it's probably related to environmental transmission. Here we have resources to be able to detect if you have H. pylori. And many people will have H. pylori and it will just be in the stomach and never produce a problem, never create inflammation or symptoms or produce bleeding. It's a bacterium that we now know lots about how to eradicate, to treat patients who have this. So in older adults, again, it's more likely to be the NSAIDs. Now, chronic atrophic gastritis means that as you have this chronic irritation, you lose the cells that produce hydrochloric acid. So the pH of the stomach is normally quite low. You have this acid. This acid is very important. It's one of our lines of defenses against things that are probably not good for us. But if you lose the cells that produce it, then you have less of it. And so when you measure the acid content of the stomach, it's less. So why is that important? Well, the acidity of the stomach affects the ionization or the chemical structure of minerals like calcium that are absorbed and that we need. So we also count on the acid being there for some medications and their absorption. So again, if you have a decrease in the acid production, it can influence things downstream in terms of their absorption. Again, these are not age-related changes. These are problems that we can see in older adults. Oop, this one got, I think, misplaced. I apologize. So atrophic gastritis, decreased acid secretion, it can affect altered drug solubility and absorption and mineral absorption. And again, if there's H. pylori, which we will see in older adults, but I suspect that's sort of a time-limited issue because as we're treating it in younger adults, we would expect in our future aging population not to see it as commonly. So I think I've already talked a bit about H. pylori. I think that should actually say highest in older adults in underdeveloped countries. So let me change that. Aspirin, another commonly used drug, can produce upper GI bleeding, as can alcohol. Other common medications include corticosteroids that you might see people who have rheumatoid arthritis on, NSAID, colchicine, which is used for gout. And one of the interesting phenomena that we're beginning to see is that for ulcer prevention and treatment, drugs known as proton pump inhibitors, PPIs, are used. And they have been around for probably 30 plus years, PPIs. So we see people who've been on them long term. They may be on NSAIDs and they take a PPI to reduce the possibility of upper GI bleeding. But those PPIs now are being found to be associated with other health problems, such as increased risk of C. difficile colitis, also with community-acquired pneumonia, and long-term, because it can affect calcium absorption, associated with higher risk of fractures. So again, it's not the gut that's aging, it's the things we're doing to it through prevention of disease or disorders that can put the person at risk, the older adult. So that's the stomach. Not a whole lot of age-related changes if you eat healthy and moderation in things that we know can be destructive. Now we'll enter what I consider to be the real black box, because, you know, with endoscopy, they can go a certain amount down, and with colonoscopy, they can go a certain amount up. And in between, we have this enormous small intestine that's composed of the duodenum, the jejunum, and the ileum. And it is large. In fact, if you spread it all out the surface area of the small intestine, I have heard compared to the size of a tennis court. So we have tremendous surface area because we have these little villi that reach into the lumen that has all the digestive enzymes that we need to break down our food so that we can absorb it. So the small intestine, again, remains healthy. It's incredibly redundant. We can lose pieces of the small intestine, hook them back up again, and that compensates over time for any injury or damage that has been done. So this is the point in the duodenum where the secretions from the pancreas and the liver come in, where the bile comes in. All of those are important for digestion. The part of the small intestine that connects to the large intestine is again regulated by a valve, the ileocecal valve. And this is an area that's very important for human health because it's the area at which the intrinsic factor, which is important for red blood cell formation, maturation, is absorbed. So that is an area that under normal healthy conditions does well. So what happens in the small intestine has a lot to do with what we absorb from our diet. And Barb, there's still a lecture on nutrition and aging in this course. Right, so I won't talk a whole lot about that, but just in terms of some of the things that go on with aging. And, you know, there's not a whole lot as long, again, as you have a normal, healthy diet. We have enough reserve capacity in our small intestine to do well. The motility, the rapidity with which things move through the small intestine seems to have only mild changes. Everything else appears well. We do, and you'll hear more about this when you hear about nutrition, we do see some decrease with calcium, decrease in iron absorption, and lactose. That's a sugar, the milk sugar, but actually that begins to decrease in childhood. You know, it makes sense that when we're first born, we have a lot of lactase. That's the enzyme that breaks down the sugar in milk. And as we mature, the levels of that enzyme decrease, which is why somebody drinks a big glass of cold milk in the morning and about half hour, an hour later may feel uncomfortable or bloated because we don't have as much of the enzyme that naturally breaks down the lactose. So any changes that we see in the motor activity of the small intestine is going to be related to medications. We may experience a decrease in all that surface area, but again, with the redundancy in the small intestine, normally we do just fine. We may see some change in secretion, but it really hasn't been studied that well in an older population or with aging. Probably the thing we are very vulnerable to are ischemic changes. The gut gets about 20% of the cardiac output. It's a very well supplied with blood. But as we get older and we develop atherosclerotic changes, those changes occur in the blood vessels of the gut. And so there can be problems if somebody is prone to having atherosclerosis. You can get ischemia to parts of the gut as well. And those are associated with aging. The risk for having ischemic changes due to blood flow decreases are more common in the older adults. We don't currently, there are some wonderful technologies, like people can swallow cameras and actually watch the gut visually, but those technologies are out there, and maybe with time we'll see greater changes that occur. An interesting thing is that celiac disease, you know what that is, gluten intolerance. It tends to be a hot topic today. People think they have problems with wheat products. You go in the grocery store and there's now, half an aisle of gluten-free products. Probably a lot of people think they have gluten intolerance, but they wouldn't meet the criteria. That is, having higher levels of antibodies. So, but there is an increase that they're finding in older adults. Again, that's not a normal age-related change. It's something that epidemiologically they're seeing a rise in older population. So that's, and with anything in the gut, in an older person, the symptoms are going to be much more subtle. So something that might be readily picked up in a child or an adult or a younger adult may be very subtle in the older patient. So, so they are more likely to have, again, cancers, but cancers in the small intestine are not as common as they are in the colon. And then the final point is increased interest in whether older adults experience a thing called small bacterial overgrowth. What that is we have bacteria in our mouth, we have it in our colon. The small intestine technically should not have bacteria in it, but there is this thought that for some individuals, you get bacteria migrating up into the small intestine and then producing changes in secretion and motility. And there are tests that they can do to determine if there is this bacterial overgrowth. So let's move on to the colon. Just to remind you all of the anatomy of the colon, again, it is that neuromuscular with the nerve layers in between the muscle layers. We have an ascending, a transverse, a descending sigmoid, and rectal anatomical parts. And this brings me to a topic that my research team has been very interested in terms of gut health. And you may have seen some growing literature in the field of the gut microbiome. It seems to be everywhere and has been linked to all sorts of very interesting conditions. We think about it in terms of whether it's related to obesity, because our gut bacteria do a lot in terms of our metabolism. We have been interested in it in terms of probiotics. So we spend as a society lots of money on probiotics because we think there's something about the microbiome and how we feel or our ability to sort of prevent diseases from occurring. So the microbiome has been associated with neurological conditions such as Parkinson's, multiple sclerosis, and even Alzheimer's. But I would say we are a long way from definitively tying those links together. Many of the studies looking at microbiome are done in mouse models, mice that are raised in germ-free environments in which they introduce bacteria or fecal material and look at whatever system they may be looking at. But it is sort of an exploding area of research at the moment. And why do we care about what's going on with these bacteria? Because they kind of outnumber us. There's just millions of them in our GI tract. They're important for the digestion of food, important for metabolism of medications. They also are important for the normal maturation of the gut. So the newborn has their gut to be fully mature, and the microbiome can make a difference in that maturation process. It's also very important for our immune system development. So we are living side by side with these bacteria that are not just transiting through, but actually affecting our day-to-day health. So just some terms that you might see out there about microbiota, which are all the organism microbiome. And then the thing that you'll see when they're talking about disease risk or bad bacteria, which is dysbiosis. So we have gram-positive, we have gram-negative bacteria, and there's some balance that occurs with these phyla, class, families, genera, all of these different parts. You have to go back to microbiology and remember the basics of bacterial system. And when that becomes imbalanced, you have too much of a bacteria that produces some metabolic end product that then stimulates the mucosa or affects the permeability of the gut. So now if the permeability is increased, you have these end products making their way into the general circulation. So what we do in our studies is we have people take a food record because what you eat can affect your microbiome. We have them collect samples, and then we have them analyze for what are all these different levels of the bacteria in the sample. We try to link that up to some of the symptoms that people are experiencing, such as abdominal pain, diarrhea, constipation, and even pain beyond the gut, such as muscle pain and back pain. And we're finding some interesting relationships. Every part of our body that has a microbiome has a different composition. So we have, the vagina has a microbiome. the oral cavity, the nasal cavity, the skin, all have bacteria. And the composition of those bacteria differ in terms of what types of family, what types of phyla are present, and what is the balance. So what do we know about normal aging? What we know is that as we get older, our microbiome becomes less diverse. Diversity is good when you're talking about the microbiome. You want to have a diverse microbiome. And so it's formed really from the moment we're born. And it makes a difference in terms of whether the child or baby was born vaginally or whether through C-section. Because if they're born vaginally, they're exposed to the bacteria of the mother as they go through the canal. If they're brought forth with C-section, they don't have that exposure, and it actually can change the composition of the infant's microbiome. It makes a big difference whether the child is breastfed or bottle fed. And there are all sorts of studies linking that to breastfed to better health, etc. And part of that is due, again, to the microbiome, or so we think. Another critical factor, and why it's very hard to study it in an older adult in terms of normal, healthy aging, is that antibiotic use. So you had how many episodes of antibiotics have you had over your lifetime? And how did antibiotics affect your microbiome? Well, it does. It dramatically affects it. And so when you read the research in this area, you want to make sure that people in some way were able to control for antibiotic exposure or any other. Where you live, parts of the world, they have different microbiomes. Is that due to other environmental factors, likely diet, likely exposures to different environmental factors? And this is just illustrating the point about the birthing route having an influence on the microbiome. I think what would be, I mean, it's very hard to capture that. Most research studies, and we certainly didn't do that in our early studies, is ask, were you born by C-section or by vaginal delivery? And whether it would in fact have influenced some of the things that we are finding. So this is an area that we are just beginning to understand how it could be linked to neurological changes. The gut is connected to the brain. We call it the gut-brain axis. It's connected by blood flow, so as we have metabolites from our bacteria, they get into the circulation. Some of these are neurotoxic, some of them are stimulating. There are substances like tryptophan that we know are important for the production of serotonin, etc., that's been linked with depression. I mean, they're just like many directions that the science is going in trying to understand the role of these bacteria in our health. Because what a simple way it would be to improve our health, to modify the bacteria in our gut. And they've done this with health conditions such as C. difficile. So somebody gets C. difficile, which is a very bad infection in the gut. They have lots of diarrhea, and it just doesn't seem to resolve. They can now do fecal transplants, where they take the feces, stool specimen from a partner, somebody living in the same house, sort of prepare it in some nice way, either in a pill or an enema or something, and give it. And about 60% of people who have fecal transplant improve. So that says something about the value of recolonization of the gut and the fact that we can manipulate the gut health and thereby hopefully improve other people's health long term. But there are a lot of struggles in studying the microbiome. It's been quite a journey. And here at the University of Washington, we have a center called CMIST, focused on discovery in terms of the microbiome and how it can be used to design therapeutics. But one of the common things that we're all seeing, it's so important how samples are collected and how they're handled, because these are bacteria. And if they're not handled appropriately or they're contaminated, we all have bacteria on us. So when we're handling it, etc., how it's processed in the laboratory, lots and lots of inconsistency. Okay, so again, just a little bit more about the development of the gut and some interesting things. A lot of this was originally done again in germ-free mice. I made this point previously about the gut-brain connection, and that this is relevant to what my group studies, in that we're very interested in that balance of microbes in the gut and how it influences permeability, because it's that permeability that can then potentially lead to activation of the immune system, as well as perhaps things that are going on in the central nervous system. So we have dysbiosis. We also, when we have that, we can develop visceral hyperalgesia, which is a phenomena where you have increased pain. So one person may have a gas in the intestine and not even be aware that they have gas, because we all have gas somewhere in our gut at any given point in time. But to some individuals, they are hypersensitive to that. And it may be that our gut microbiome are contributing to that. So I'll just move on to that and talk about inflammation. So we've talked about the colon in terms of the microbiome, and one of the things that dysbiosis can result in is inflammation. We are beginning to see in our older population an increased number who develop inflammatory bowel disease. Now, inflammatory bowel disease, which is ulcerative colitis and Crohn's disease, those are the two IBD conditions. We used to think of it as a young person's disease, adolescents, young adults who would develop this inflammation that was very heterogeneous, meaning that some people just had a single episode, whereas for others it became a lifelong condition. And so now to see it in older populations, perhaps because we have more people living longer, or it may be related to some of those blood flow changes that we talked about in terms of having more ischemia. And whenever you have ischemia, you have the potential for inflammations. So we're seeing this epidemiologically, and the rates of Crohn's disease and ulcerative colitis increasing. What is problematic about that is that one of the things one worries about when you have that inflammation of the colon is you have all that mucosal lining that becomes inflamed, and the older person may not have the cardiovascular reserve to deal with the blood loss that occurs. So when older individuals are diagnosed with IBD, they have higher risk of complications because the regenerative ability of the gut to replace itself decreases as we get older, and again, the compromised blood supply. So this is sort of an interesting phenomena. Again, not normal aging, but disease related. I'll just make a comment about C. diff. I mentioned it in terms of the fecal transplant, but we worry about C. diff when it occurs in our older patients. Again, if there is a lot of diarrhea, there's fluid loss, electrolyte loss, more vulnerable to cardiovascular effects. And so we see this in hospitalized patients, and we've identified risk factors such as people who have nasogastric tube down, anybody that's had perhaps the gut microbiome disrupted. We all go for our every 5 to 10 year colonoscopy, that disruption of the normal flora of the gut. All of these things may put older individuals at risk for developing this type of infection. And I mentioned earlier about the use of antibiotics may also predispose, as well as anything that affects the gut bacteria. Okay, now we come to the fun part, constipation. Constipation is not a normal age-related change. It is not. It is not. What it means is prolonged gut transit or difficulty evacuating the bowels. You know, one of the things when you study the gut is about symptoms and asking people about their bowel habits. Either you get an individual who loves to tell you about their bowel symptom, but the problem is that what you call constipation may differ from what I call constipation. For someone who has 7 or 8 bowel movements a day, and that's normal for them, to go for a day without a bowel movement is constipation. Or they're still having 3 or 4, but they're more difficult to pass. It is such a personal assessment in terms of whether you have diarrhea or constipation that I always tell nursing students that they need to carry what's called the Bristol stool chart, which is a little figure with numbers associated. It has pictures of stools, you know, from little hard rocks to completely liquidy. And it's important to quantify that because we all have a different perception of what constipation is. And so we know that in nursing homes, we see problems with constipation. We do know that people who are immobile, who have chronic illnesses, who are on medication, all of these factors, again, those anticholinergic agents, all of these are associated with constipation, and it is a troublesome symptom. It very much affects your quality of life. It affects whether you want to go out and do things, go to work, or travel with constipation. So from animal studies, of course, they can biopsy the tissue and look at the tissue. As we get older, just like in our brains, we lose neurons. But that should not account for the problem of constipation. So again, we know from epidemiological studies that both constipation and fecal incontinence increase as people get older. And again, some of the things it's related to, and I think I've already mentioned that. Women tend to have greater impact in terms of self-report of how much does your constipation bother you. So what will put you at risk? Well, anything that will decrease the transit or the motility of the gut. And by the way, transit is an important factor in terms of gut bacteria. When you have diarrhea, the diversity of your microbiome decreases because things are moving through quickly. So constipation, inactivity, low fiber diet. A really important one is decreased inadequate fluid intake. We need fluids to get our stool nice and movable. And of course, hemorrhoids, where it's painful to defecate. We know that constipation is associated with anxiety and depression, but what's the cause and effect? We don't know. Is it that one came before the other? We don't know. This I find interesting, that 28% of older adults have problems with fecal soiling. I would say fecal incontinence is an undisclosed problem. It's highly prevalent, and it's not something that's probably gotten the sort of attention that it needs. I'm not going to talk about IBS, even though it's my favorite topic, but it's not as relevant to today. Oh, I do have a picture of my stool chart. This is on the web. It's called the Bristol stool chart. And again, you can get it laminated and carry it in your pocket if you're a clinician. So, you know, we use it a lot in our studies because we try to help people who have these chronic symptoms that are not related to pathology. So we spend a lot of time educating people about their symptoms and its impact. We also talk about stress reduction, because stress tends to activate the gut. Remember, it has that gut-brain connection. And while stress does not lead to ulcers per se, it can affect your motility and the secretion in the GI tract. I think I'll skip. And here's another example of where stress can affect the gut. They did this interesting follow-up study where there was a bacterial outbreak in Canada. It's probably been 15 years ago, where it got in the water supply. It was Campylobacter, I believe. And so they followed the people, and some people had some really bad outcomes, like went into kidney failure and all this. But they followed the people, and they were tracking their gut symptoms afterwards, who had diarrhea, who had pain, etc. And what was interesting is they went back and they found that the people who had acute enteritis due to this particular bacteria, if they were stressed at the time they had the enteritis, they were more likely to have symptoms later on. So stress will affect your perception of how well your gut is functioning and the symptoms that you experience. So we recommend that chronic functional complaints, diarrhea, constipation in the older adult should always be investigated. And part of that is driven by the fact that in this country, we have a relatively higher rate of colorectal cancer and should be screened for. Let's see. I wanted to just make a few comments about fecal incontinence, that it's the involuntary passage of stool. You can have soiling as well as complete loss of stool, that it's common even in community-dwelling older adults, very common in nursing home and in hospitalized patients, and people who have urinary incontinence also have fecal incontinence. So just be aware that those things often travel together. Fecal incontinence, as I mentioned, has a psychological impact, reduced quality of life, and probably most important, leads to social isolation, a desire not to go out. When we first started looking at irritable bowel syndrome, where people have diarrhea and/or constipation, in listening to their personal narratives, what really struck me is the decisions they were making in terms of their lives. I won't go out to dinner. I won't go shopping because I don't know where the bathroom is. I won't get on an airplane. I won't be visiting family. You know, their life becomes the world becomes smaller and smaller. And it's because of the impact of these disorders on their lives. So there are a number of things that can result in fecal incontinence, particularly for women as they get older, which is trauma or surgery, also anything central neurological conditions, dementia, immobility, the lack of perceiving that the rectum is full and that they need to defecate. So just to show some pictures, there are sphincters that control it. Some of these very much under cognitive control and can produce. And I'll just do another one that just shows risk factors for fecal incontinence, because I do think it's not fully appreciated. Let's see what else I have. Diarrhea is on the other end of the spectrum, and we know that there are a lot of different drugs and agents that can lead to diarrhea. In the older adult, this is because of concerns about fluid loss, electrolyte loss, etc., that it is a more troublesome concern. Let me see what else I have. Okay, and I'll finish up by just saying a few words about colorectal cancer. It's a common lethal disease, third most common in the world. In the US, we're fortunate with all the screening that's going on that the rates are showing a slight decrease. I think also it's helped that the guidelines continue to change, and the age at which one should have your first colonoscopy has decreased over time. So it went from 55, 50, and now I believe it's 45, at least in high-risk population. Men are more likely to develop this than women. It's associated with a low socioeconomic status, but nobody is really immune. Age is the critical factor, although I don't know if you've seen the recent news where we're seeing more cases of colorectal cancer in younger adults and trying to understand what is causing that. We know there are hereditary forms of colorectal cancer, but for the most part, we just encourage people very much to follow the screening recommendations. What are the risk factors? Well, if you have polyps, and so polyps are considered perhaps dysplasia that may be forerunning to developing colorectal cancer. People who have inflammatory bowel disease, and this is often a high-risk group that's followed. Ethnicity, diet, a lot of talk about red meats, processed meats, again, epidemiological studies. People who are obese are at greater risk, and diabetes. Now this is a bit of a normal age-related change. I think if we all live long enough and we all have an autopsy done on our bodies, they will likely find a diverticuli. And the diverticuli, if you think of a polyp being a growth that occurs into the lumen, so it's growing inward, diverticuli go outward. They're like little outpouchings on the intestinal wall. Problem is those little outpouches can get stuff stuck in them and create inflammation and possibly infection, resulting in diverticulitis. So they can be symptomatic or asymptomatic. They're age dependent. Most of them occur in the sigmoid. It's just due to changes in the muscle layer of the gut with aging, possibly related to diet. There used to be a lot of don't eat this and that if you have diverticuli. That's really not been proven that people with diverticuli can actually eat popcorn, that's okay. And as I mentioned, again, obesity, which is related to a number of health problems, diverticulosis. This is just a fun picture of a polyp, like I meant, that said earlier, these are things that grow into the lumen. And people who have polyps need to be aware of the screening guidelines. And I'll finish with this, which is my favorite organization for finding educational materials, which is the International Foundation for Functional GI Disorders. They've always had very up-to-date materials, along with the American Cancer Society, NIDDK at the NIH, and the American Gastrointestinal Association. Lots of information. I would also say I wish we knew more about aging. I would think after all these years of giving this lecture that there would be newer information about the gut, but apparently it's just as durable as it was 30 years ago when I first started giving this lecture. And I would be happy to entertain any questions that you might have. Thank you. Thank you.
So I do have one question from a site, and I'm not quite sure I understand it, so they might need to weigh in. But the question says you wrote stool passage generally under 3 days, and the question is 24 hours normal?
To have a stool passage. Yeah, that's a good question, and I'll just rely on, everybody is so individual and very much dependent upon age and very much dependent on gender. I did this study, I participated in a study with bioengineers years ago, where as we were trying to develop a tool to measure small intestine motility. And we had this device that we all swallowed. And the engineers I was working with at the time were clearly all over probably the age of 60. And this device happened to be a magnet. And so when it passed, we would all know it passed. You could see it in the toilet. And the other problem was it's stuck to the plumbing, and some people had problems with plumbing afterwards. But what struck me was for them, it could have been anywhere from 3 to 5 days. But for me, it was within 24 hours. And that makes it really hard when you're trying to study passage in the gut, because clearly things were moving more quickly. And one of the first studies I did was with women, and I was interested in menstrual cycles, because a lot of women have diarrhea associated with menses. And I thought, why would that happen? And we used to put blue dye in this liquid that we would have them drink. And for many of the women, if it was the first day of their menses, the blue dye would be out clearly within 24 hours. And for many of our women, even if it wasn't first day of, it was sooner than that. So a lot of it has to do with sort of your natural habitat and likely what's living in your gut with your bacteria. I hope that answers the question. And normal bowel, like I said, there are people who have 7 or 8, 10, 12 bowel movements a day. And there are some people, the longest has probably been 2 weeks, or I think there are some reports out there of even longer. Yeah.
I had a question. It was one of your slides, and it was titled "There Are Age Differences," and then you had the babies all the way up to the older adults with lots of circles. And I wasn't clear what the circles were telling us.
Okay, what I was trying to say is that the diversity, so the composition of the bacteria in your, this one, that it changes. So if you look at the composition over here, these Firmicutes, the Proteobacteria, Actinobacteria, all these, that when you're younger, you notice that the reds, the Proteobacteria, are a bigger percent. And as we get older, it becomes more Firmicutes, which are,
Yeah, I guess I just didn't,
I'm sorry.
I didn't understand those words.
Yeah, those are the phyla of the bacteria. Yeah, and so
The more red you have, the better off you are.
when you're young, it's good to have it. It would be nice. to have it, but you'll notice with our healthy child, see, it's not just the phyla. Underneath the phyla, there are all sorts of families often, and underneath those families, there are genus of bacteria. And so sometimes you can have Firmicutes that are mostly of this type of family versus another. It's just so complex. I think the only message I wanted to give was that it changes as we get older.
No, that I got, but I went, thank you.
Yeah. And so in this situation of malnutrition, you'll see this distribution, which again, it's just different. Thank you. Good clarification.
Missoula is wondering if you could briefly comment on the relationship among gum disease, GI ulcers, and heart disease produced by H. pylori.
I will plead ignorance on H. pylori and gum disease. I don't know that literature. H. pylori and ulcers, yes, H. pylori is associated with ulcers. And that's why, you know, it produces, the H. pylori itself produces an enzyme which tends to be destructive to the gastric mucosa and results in vulnerability to the acid and the pepsin and everything else that's there. And that's why for treatment, they give antibiotics to eradicate the H. pylori. That's an interesting question about the oral. And I'm trying to think, when people do have regurgitation of gastric content, so you're laying down at night, your gastric contents go to the back of your throat, you can develop dental caries. You can, in fact, it's been thought that that might predispose to asthma because you aspirate a little bit of that stuff into your airways as well. So it would make sense that if you have that acidic stuff in the stomach, in the mouth, it could predispose, but is there a direct link? I just can't comment on. Good question. Maybe they know. Do they have some evidence?
I don't know.
Well, he'll let us know. Another question is, can poop actually cause plumbing problems like a stopped up toilet? And if so, what can be done? I don't know if that's...
Sounded joke.
I don't know. It seems like the answer is yes, and call your plumber.
Yes, that's a great, I like that answer.
It looks like that's all the questions that we have from our audience. That was the great grand last one. Do we have any others from the audience? All right.
What a question.
Very much.
Just when you think you got every